Pod. Okay. Today we're going to talk about the Guillain-Barré Syndrome, and it's a demyelinating disease of the peripheral nervous system. And it's, you can also say an acute meaning that it comes in a short period of time, immune-mediated polyneuropathy. Poly. uh Now let's break down everything. So it's an acute immune-mediated condition that affects the peripheral nervous system. So the way it does, it demyelinates. You can, as you remember, when we were talking about, go back to your neuro anatomy of the CNS, and let's look at a neuron. A neuron has dendrites, a cell body, and an axon. And the axon have myelin sheaths that help in the proper conduction of impulses. So it's a demyelination. Now we break down this myelin, the myelin sheath. Now, can see this. You guys can see the. Let me just remove the chat box because I can't see the slides properly with the chat box. So, the cause of Guillain-Barré is not really known. Like, you can't say there's one specific cause, but it usually comes to, a couple of weeks, like 2 to 3 weeks after the infection, within 6 weeks of an infection of the upper respiratory system or GI. So some of the associated pathogens are, they can be bacterial or viral raw. We have Campylobacter jejuni, Mycoplasma pneumonia, cytomegalovirus, EBV, or HIV. So a person will tell you they had a cough like 2 weeks ago or 2 weeks ago, and that's when they started feeling. Now that comes after the Guillain-Barré, the symptoms that they present with come after this presentation. And now we're going to see, as we saw, it's a demyelination. So we're going to see how this demyelination happens. It's usually, as we have said, demyelination is the destruction of the myelin. So that breaks down the communication between neurons, and it's usually segmented. I don't know if you can see. On this, we have the myelin sheath, the myelin, which is a sheath that covers the axon. So demyelination is going to leave this like this. So the impulse does not travel properly. It's distorted, as you can see. The upper image is a normal neuron. The lower one is when we have the demyelination. So we're going to talk about we have seen that it comes after an infection. So in the history, you're going to come up with alikuwa na homa, alikuwa na, they had some infection of the GI, and most of the times they will have gone to these are the associated pathogens. So, and then we talk about the pathogenesis. It's usually caused by molecular mimicry. Do you remember the immunology and molecular mimicry? So some pathogens, like for example, Campylobacter jejuni, it has the oligosaccharides, the things that form the cell body on the surface of the Campylobacter, they mimic gangliosides which are found on motor neurons. So because they look together when the body is about to fight the oligosaccharides, when the body is making antibodies against the oligosaccharides on the body of the bacteria, in the pathogen. In this case, we're talking about Campylobacter jejuni. Then the body is also going to attack the gangliosides. I don't know if this is a far-fetched and there's no time, so I don't know, should we go through the gangliosides? Do you guys want to go through that? They usually help, they're involved in cell-to-cell interactions, modulation of receptors, regulation of growth, and they're on plasma membranes of cells. So the antibodies target these gangliosides, and these gangliosides are abundant in human nervous tissue in the nodes of Ranvier. So if the body is fighting the oligosaccharides for the pathogen that's attacking your body, it will also break down these gangliosides, which are a component of the neuron, of the plasma membrane of the cells. So the what we're going to talk about, I would give you a case example, but there's no time. So let's continue. So we have molecular mimicry. It tricks the immune system, so the immune system attacks the gangliosides found on motor neurons. So, now here we're talking about the whole helper T cells. Helper T cells activate B cells and macrophages. So neuronal autoantigens like auto on their cells are presented to helper T cells by antigen presenting cells because they mimic the other ones for the pathogen. Then cytokines, T cells activate the B cells and macrophages, and then the B cells produce antibodies that target myelin, leading to segmental demyelination, which is this. You can see that we have demyelination, but it's not entire demyelination. It's a segment of the axon, the myelin on the myelin covering the axon. It's a segment that's usually attacked. So we have two mechanisms, demyelination and axonal. It's mostly an acute, if we go back here, acute immune mediated. Do you see why it's called immune mediated? Bill, why is it called immune mediated?
So it's normally it's a damage caused by activation of the immune system. So, for example, you said if you're infected by Campylobacter jejuni CMV, there are the antibodies generated against Campylobacter jejuni also attack the gangliosides
Mm.
that are found in the segments of those nerves. So the autoantibodies now attack the ganglioside, then we have axonal degeneration. So there is an immune involvement.
Yes. The T cells, the B cells, the macrophages, and then they attack the myelin. Okay, thank you so much. And then two mechanism, we have demyelinating, acute inflammatory demyelinating neuropathy, axonal, which may be motor or sensory motor. And it's usually a predominantly cell-mediated inflammatory response to the myelin protein of spinal roots, peripheral and extra axiocranial nerves. Now, these are the ones that are targeted. It's probably triggered by, yeah, this is what we've talked about. There is release of inflammatory cytokines that blocks nerve conduction and is followed by a complement-mediated destruction of myelin sheath and the associated axon. It is a monophasic disease and does not recur. So we've talked about all that. What does the demyelination cause? It causes a disrupted communication between the neurons. So the impulse is not going to be traveling properly, as we have seen. Like you're seeing, the message now is not flowing properly, it's distorted. So the demyelination causes disrupted communication between the neurons and sensory, motor, and cognitive impairments because these axons go they're the ones which take the impulses from the brain to the rest of the body. So we have sensory, motor, and cognitive impairments. Next, so obviously this is IMED, so we're going to see how this presents. We have seen that it is acute, so the presentation is going to be acute. Sorry, it's going to be acute or subacute in onset, and we have a rapid progression of the symptoms. So what some of the symptoms that the patient is going to say is bilateral ascending limb involvement. They usually start from the limbs upwards. And then we have flaccid paresis or paralysis, hyporeflexia, or areflexia, pain, nociceptive or neuropathic. We can have cranial nerve involvement. Now, if the axon was going to a cranial nerve, as we have seen here, sorry, here there's cell-mediated response to myelin protein of spinal roots, peripheral, and extracranial nerves. Now, extra-axiocranial nerves. So depending on which myelin sheath has been, that's if it's in the peripheral nervous system, we're going to have bilateral ascending limb involvement, flaccid paresis or paralysis, hyperreflexia or areflexia. These are some of the symptoms the patient is going to present with. Nociceptive or neuropathic, we have cranial nerve involvement. If maybe the face is involved, we're going to have facial diplegia, ophthalmoparesis, and autonomic dysfunction. If it has gone to the autonomic nervous system, we're going to have cardiac arrhythmias, blood pressure fluctuations. Now, the or respiratory failure risk. This, keep in mind the respiratory failure risk because it happens in like most of the patients, like 20%. Now we're gonna talk about a focused history. Obviously, the basis of this is a focused history and physical exam. So some of the symptoms you're going to see history, as we have seen, it comes after an infection, about 6 weeks within about 6 weeks after an upper respiratory tract infection or gastroenteritis, viral, bacterial, and then we're going to have progressing. The patient is going to tell you it started in the limbs. I was feeling tingling, numbness, weakness, then it ascended. They might have facial weakness, difficulty swallowing or speaking, blurry or double vision. And then on physical examination, the body temperature and mental status are usually normal, but we might have bilateral symmetric, because it affects both sides. Bilateral symmetric sensory loss and weakness, decreased muscle tone might be reduced or absent deep tendon reflexes. Now, we have some subtypes of Guillain-Barré syndrome. Some of these subtypes, we have acute inflammatory demyelinating polyneuropathy. This is the most common. It's usually caused by demyelination, and it's associated with Campylobacter and CMV. And we usually have pain and cranial nerve involvement. So we're going to have the other facial symptoms. And then we have axonal loss. And this axonal loss, can have acute motor axonal neuropathy. This affects the motor, or acute motor sensory axonal neuropathy. It's faster progressing, slower recovery, and the progression of this axonal loss is going to be different from the acute inflammatory demyelinating polyneuropathy. Now we have some variants, which this is what's most important. There's a variant of Guillain-Barré called Miller-Fisher syndrome. You have to know this triad: ophthalmoplegia, ataxia, and areflexia. So this patient is going to have this triad: ophthalmoplegia, ataxia, and areflexia. And then the Bickerstaff, Bickerstaff brainstem encephalitis, we're going to have the Miller-Fisher with impaired consciousness. So at Aquan, they're going to have ophthalmoplegia, ataxia, and areflexia with impaired consciousness. I would like one of you guys to remind me, what is claret? Claret. What is each one of you? Abdil, Bill, claret. Explain each. No, Bill has already answered. Abdil, claret, and happiness. What's ophthalmoplegia? What's ataxia? What's areflexia? Guys, you know this.
So hemiplegia
Yes.
is the paralysis of one or more extraocular muscles. So you now have, like, if you are the extraocular muscles are paralyzed, your vision, so visual reflexes zitakuwa impaired.
Yes. And then ataxia.
Ataxia is a lack of coordination of voluntary movement caused
Yes.
by cerebellar and impaired cerebellar function.
Yes. And then areflexia. This one is straightforward. We're going to have no. Yes, completely no. And then for Bickerstaff, we have MFS, Miller-Fisher, with impaired consciousness. So they're going to have ophthalmoplegia, ataxia, areflexia with impaired consciousness. Thank you, guys. Thank you so much. Next, we're almost done, I promise. Now we're going to see this one I'm just going to brush off. So what are we going to do for this patient? So we're going to have CSF analysis, and in the CSF analysis, we're going to have increased protein, but the white blood cells are going to be normal. Then we have 3 exams we can do: CSF analysis, nerve conduction study, or electromyography. And we're going to have conduction for nerve conduction study. Now, you remember we've talked about how the message impulse along the axon is distorted. So we're going to have conduction delays, which are signs of demyelination or axonopathy. And then we can do an electromyography, which was muscle denervation, because now the axon that goes to that muscle is going to be, we can have demyelination, like it's completely distorted. So that muscle is not going to be having an impulse in it. Summary, this is an acute monophasic inflammatory, sorry, I've covered my whole screen. Acute monophasic inflammatory polyradio neuropathy, and it typically follows a respiratory or GI infection. Key features, we have symmetric ascending sensory loss, keyword ascending paralysis, guys, because this is what differs it from transverse myelitis and other polyneuropathies. And then we have reduced or absent reflexes, because now the axon that goes to that muscle is distorted. So we can have, based on the level of the demyelination, we can have reduced or absent reflexes, and then it's diagnosed by CSF analysis, nerve conduction studies, and electromyography. Are we together, guys? We're done. So do you have any questions?
Maybe question. I have one.
Yes.
So for the clinical presentation, you
Yes.
said there were the limb involvement, so ascending paralysis.